Hello, everyone, and welcome to today's webinar, The Management Challenges of Antithrombin Deficiency in Pregnancy. My name is Dr. Evelyn Lockhart, and I am the Medical Director of Transfusion Service at the University of New Mexico Health Science Center. I will be moderating today's webinar. Next slide, please. The Foundation for Women and Girls with Blood Disorders mission is to ensure that all women and girls with blood disorders are correctly diagnosed and optimally managed at every life stage. To this end, we aim to provide education to healthcare providers on the medical consequences and unique issues for women and girls with blood disorders. Next slide. Today's presenters are Dr. Andra H, Consulting Professor of Obstetrics and Gynecology in the Division of Maternal Fetal Medicine at Duke University Medical Center, and Dr. Barbara Konkle, Associate Chief Scientific Officer at Bloodworks Northwest, Associate Director of the Bleeding Disorders Program of Washington, and Professor of Medicine and Hematology at the University of Washington in Seattle. Next slide. The Activity Medical Director for today's webinar is Dr. Andra H. The Planning Committee for today's presentation include Dr. Barbara Alving from University of Maryland, Dr. Barbara Konkle, Dr. Roshni Kulkarni from Michigan State University, Dr. Kenneth Mann, formerly Emeritus Professor of the University of Vermont, James Munn from the University of Michigan, Dr. Jennifer Dietrich from Baylor College of Medicine in Houston, as well as myself. Next slide. In accordance with Creighton University Health Sciences Continuing Education Policy, the Faculty and Planning Committee for today's webinar have disclosed any significant financial interests or other relationships of interest relative to the topics that will be discussed during this program. Such disclosures allow you to better evaluate the objectivity of the information presented in the lecture. You may learn more about this at the Foundation's website, fwgbd.org. Next slide. To ensure the best sound quality during the webinar, all attendees will be muted. However, all attendees will have the opportunity to participate in a question and answer session with the instructors at the end of the webinar. You can submit your questions during or after the webinar via the chat box in your GoToWebinar control panel on the right-hand side of your screen, and we will address them during the Q&A session at the end of the presentation. We gladly welcome your input. Next slide. This learning activity is offered through the Creighton University Health Sciences Continuing Education Department, which has been accredited for offering 1.0 AMA PRA Category 1 credits for physicians and 1.0 contact hours for nursing professionals. Next slide. At this time, we would like to have an audience participation poll. We're curious to see how many are watching this webinar with you today. Please enter your choice and we'll report the results shortly. All right, at this time, it looks like the majority are watching this webinar solo, but we're also glad to see that some have invited colleagues or friends to also attend this webinar. Looks like about a third of you have at least one other person watching the webinar today. We will be having some audience participation questions in the webinar today, which will be following this format. The following are the learning objectives for today's webinar. For those who wish to refer to these later, we will record and archive this webinar on our website, fwgbd.org. I would now like to introduce our first speaker, Dr. Andra James.
Next slide. Hi, it's a pleasure to meet with you today. I'm going to start off with a case, and then Dr. Konkle is going to comment on it, and I'll wrap up at the end. The patient was a 20-year-old gravida 1 at 29 weeks gestation. She was transferred to our institution with a large left iliofemoral deep vein thrombosis and new symptoms of pulmonary embolism despite 3 days of full anticoagulation. She'd been receiving enoxaparin 80 milligrams subcutaneously twice a day. She had a BMI of 27. She had a swollen left lower extremity. She'd had a VQ scan that showed high probability pulmonary embolism. She had an obstetric ultrasound that was essentially normal for her gestational age. She'd had a complete blood count and comprehensive metabolic profile, which were normal. Next slide. On hospital day 2, she had an anti-10A level of 0.25 international units per deciliter. Target range, as you may be aware, is 0.6 to 1 for enoxaparin. It was increased from her 80 milligrams twice a day to 100 milligrams twice a day. On hospital day 3, her anti-10A level was 0.4. Her enoxaparin was increased to 120 milligrams twice a day. On hospital day 4, her anti-10A level was no higher at 0.36. Her enoxaparin was increased to 150 milligrams twice a day. And on hospital day 5, her anti-10A level was 0.51. The hematology service was consulted, and the hematology fellow recommended starting bivalirudin. Next slide. What would you choose for this patient with what appears to be heparin resistance? Would you choose unfractionated heparin, bivalirudin, argatroban, antithrombin concentrate, or enoxaparin at a higher dose? I'll give you a chance to choose. Okay, let's see what you said. Well, 2/3 of you chose antithrombin concentrate. We think this is heparin resistance, so we might not get any better effect with heparin. Bivalirudin crosses the placenta, and there are no reported cases of its use in pregnancy. It is used for heparin resistance outside of pregnancy. So is argatroban. There are reported cases of argatroban's use in pregnancy, but antithrombin is a big molecule. It doesn't cross the placenta, and it can be used in heparin resistance. And everybody could see that providing enoxaparin at a higher dose wasn't going to get us anywhere. Next slide. So when might we use antithrombin concentrate in pregnancy? For women with current thrombosis, antithrombin deficient women with recurrent thromboses despite anticoagulation, and antithrombin deficient women when anticoagulation is desired but contraindicated. And in this case, we chose it because we had a woman with a current thrombosis who was heparin resistant. Next slide. Interestingly, her antithrombin level was 44% of normal. Dr. Konkle will talk about the pitfalls of trying to diagnose antithrombin deficiency in the circumstance of an acute venous thromboembolism. On hospital day 6, she got her first infusion of antithrombin concentrate at the recommended dosing by package insert, and then for maintenance doses, she got 60% of the loading dose every 24 hours to maintain her antithrombin levels in the 80 to 120% range. Next slide. On hospital day 7, her antithrombin level was 93%, up from 44%, and her anti-10A level was now greater than 1, beyond target range. Her enoxaparin was decreased to 100 milligrams BID. After discharge, she received weekly infusions with antithrombin concentrate. At 38 weeks gestation, the amniotic fluid volume dropped, suggesting uteroplacental insufficiency. The enoxaparin was held. She was admitted for an antithrombin infusion. Her induction of labor was started 12 hours later. Her enoxaparin was resumed after her successful vaginal delivery and continued. She was continued on antithrombin concentrate until discharge. She went home on her full anticoagulation, and 6 weeks later, her antithrombin level at what we presume might have been baseline was 48%, suggesting she might have true antithrombin deficiency, but she reported no family history, and she had had no other thromboembolic events. Next slide. I'd like to turn the program over to my colleague, Dr. Barbara Konkle from Bloodworks Northwest, who will talk to you about laboratory diagnosis of antithrombin deficiency.
Hi, everyone, and thanks, Andy. And it's my pleasure to talk to you today. And as Andy said, we're going to talk about how antithrombin works and then how we measure it. And I'll come back to some thoughts about the patient that she just mentioned. So antithrombin, this shows a coagulation cascade. And antithrombin inhibits a number of serine proteases in the coagulation cascade, but most notably activated factor 10 or factor 10A and thrombin or factor 2A. And this inhibition activity is increased with binding to heparin. And so if I may have the next slide. And this just shows that in number 1, you show antithrombin, and it has a heparin binding site, which might bind to the heparins on the endothelial cell wall or to therapeutic heparin, either unfractionated or low molecular weight. And then there's another part of antithrombin, which is what we call the reactive site, which is designated by an R. So when antithrombin is bound to heparin, then there's a conformational change in the reactive site, which makes it able to inhibit thrombin. For thrombin, thrombin also has to be bound to heparin, whereas for factor 10A, it only has to be bound to antithrombin. And that's why the anti-10A assay is a better assay if someone, in measurement of the 10A for low molecular weight heparin. Sorry. Next slide. So here is a slide illustrating the risk of thrombosis with different inherited thrombophilia. And as you'll note from this, that if we look at the prevalence of patients with thrombosis, antithrombin deficiency is uncommon, but the relative risk of thrombosis is significantly higher than with the other deficiencies. And if we go to the next slide, this is a Kaplan-Meier type plot looking at the ability of being thrombosis free over years. And the reddish line is antithrombin, which is lower. You can see with the others that people actually have a better chance of being thrombosis free than having a clot in their lifetime, which is not true in the study in patients with antithrombin deficiency. Next slide. But the picture is a little different when we look at different populations. So those studies that I showed you initially were studies of families with thrombosis. So if we look in thrombophilic families, and we look in families with antithrombin deficiency, there often is a lot of thrombosis, and those individuals have a high risk of developing thrombosis. When we look at the population as a whole, antithrombin deficiency doesn't look nearly as strong of a risk factor as shown in the first column of this slide, which shows the prevalence in the general population, the prevalence in consecutive patients with VTE which is similar, but the risk of recurrent venous thrombosis here is not so strikingly different from protein C deficiency or even protein S deficiency. And that is in part related to the challenges in measuring antithrombin deficiency. So there are a number of things that affect antithrombin levels that don't reflect a true deficiency. And patients may be diagnosed with antithrombin deficiency who really aren't at risk of thrombosis, and we need to be aware of that. So if we go to the next slide, so how do we measure antithrombin? Well, first, just to complicate things, there are several types of antithrombin deficiency, and here's shown 4, and I always remember the family who came to see me and said, could you please explain the 3 types of antithrombin deficiency to us, which I was a little taken aback. But the most common and what we think of in terms of antithrombin deficiency is type 1, which is autosomal dominant. There's decreased protein function and decreased protein amount. It is the most common of these rare disorders, and it's definitely associated with an increased risk of venous thromboembolism. There are then other types which aren't necessary to dwell on. The one that's most easy to diagnose is the reactive site, the type 2 RS or 2A, where there is a normal amount of protein but decreased protein function. And that may have an association with thrombosis, although probably less than with type 1, although the numbers are very small in terms of to understand this. And then there are other variants that patients may have a diagnosis of, particularly historically, where we don't really know how associated they are with an increased risk of thrombosis. Next slide. So in testing for antithrombin, we usually start with an activity assay, and we'll go through how that's done in the next slide. It can be based on thrombin activity or 10A activity, and there are reasons and modifications in the assay to try to get the best result. And then if the activity assay is abnormal, we will use an antigen assay to confirm or further analyze, and those are done by ELISA or immunoturbidimetric assays. Of note, though, you'll see that the coefficient of variation is relatively large on those assays, so certainly patients who have borderline values may still be normal, but have a borderline abnormal value. Next slide. So when we do the activity measurement, we take the patient's plasma and we add heparin and then either excess factor 10A or thrombin to it. And then the patient's antithrombin will inhibit the 10A or thrombin that we've added. So then we can measure what's left by using a chromogenic substrate, and that what we get will be inversely proportional to the patient's antithrombin activity. Next slide. So what about things that affect levels? So in terms of life stages, at birth, the levels are lower than normal range. So in a family with antithrombin deficiency, you would not want to test a child at birth. It rises to adult normals by 6 months and actually tends to be a little higher than the adult normal range for much of childhood. It's lower in premenopausal versus postmenopausal women compared to men. Next slide. And there is a slight decrease. This was a study done by my co-presenter. And there is a slight decrease throughout pregnancy, although clearly overlapping in values. Next slide. This is a study of 1,837 healthy adults where there appeared to be a decrease in men as they age. Next slide. And this looks at hormonal contraceptives, that it is a little lower in women taking hormonal contraceptives versus those who are not. And I would say that there's not a link here with a risk of thrombosis, that has not been demonstrated. Next slide. And then there are a lot of conditions that affect antithrombin levels. So when you see a patient who was hospitalized and has a low antithrombin level, you have to really be very skeptical. And so here are just some of the things that can affect antithrombin levels: liver disease, disseminated intravascular coagulation. Patients who have large thrombosis have a drop in antithrombin levels, surgery, sepsis, inflammatory bowel disease, inflammation, malnutrition, nephrotic syndrome. So if someone's sick, you can't really trust that they have a true baseline antithrombin level. Next slide. So what's considered deficient? So if you have a patient with mildly decreased antithrombin levels, you really need to examine pre-analytic variables and question the significance, and your family history will really help you. So in the patient that was presented, clearly her antithrombin level was low, and she was treated to increase the antithrombin level with therapeutic effect and did well. And that was a great outcome. And at some point, she had another antithrombin level that was low. I would, though, still have my little hat of skepticism on to say, is this woman really have inherited antithrombin deficiency because of the lack of a family history? So I would want to repeat that value at a later date, and if possible, test her parents to really understand the deficiency if present in the family. This is a rare disorder, so it's the kind of setting where we like to do family studies and really understand what's happening in the family and what risk that puts to family members. As I said, for type 1 antithrombin deficiency, it's usually highly penetrant and you get a positive family history. So should we worry about mildly decreased antithrombin levels? And these would be levels above the value of the person who was presented. And there was a very nice study published in Blood last year that found that for the mildly decreased values, there was a non-significant increased risk, but it was really, relatively large study, did not reach significance. But when the value got lower, there was a significant risk. And so that is reassuring that if we have these values we don't quite know what to do with, it's probably okay not to do anything with them in women without a history of thrombosis and without a family history. Next slide. So key points is antithrombin assays include measurement of activity and, if needed, antigen levels, and there can be further specialized testing if needed. Inherited antithrombin deficiency is rare, and antithrombin levels are affected by a bunch of stuff. So most abnormal, particularly borderline values in unselected patients, are likely false positives. So we always need to be skeptical so we're sure, such as the woman who was presented, we want to be sure that the right diagnosis follows her through life because she's going to have further issues, and how we manage her will depend on that. So thank you, and I will now turn it back to my colleague, Dr. James.
Thank you, Barb. Next slide. So here's the second case. We have a 28-year-old gravida 2, para 0. She's 8 weeks gestation with a history of recurrent venous thromboembolism, known antithrombin deficiency, a family history of venous thromboembolism, now with new left lower extremity deep vein thrombosis on questionably adequate anticoagulation. Supposedly she was taking 1 milligram per kilogram twice a day of enoxaparin. But she was sent to us for consultation regarding need for antithrombin concentrates during pregnancy. Her BMI was 33. She had a swollen left lower extremity. She had an ultrasound that was compatible with her obstetric ultrasound that was compatible with her gestation. She had a complete blood count and comprehensive metabolic profile, which were normal. Her antithrombin level was 53%. Next slide. So what would you choose for this 28-year-old gravida 2 at 8 weeks gestation with known antithrombin deficiency, a history of recurrent venous thromboembolism, now with new left lower extremity DVT? I'll give you a minute to choose. Enoxaparin at a higher dose, enoxaparin at the same dose plus antithrombin concentrate, IV unfractionated heparin, warfarin, or a direct oral anticoagulant. Okay, let's see what you chose. Enoxaparin at a higher dose. Most of you chose, almost 3/4 of you chose enoxaparin at the same dose plus antithrombin concentrate. 11% were willing to try IV heparin. Some were willing to try warfarin, and nobody was willing to try a direct oral anticoagulant. We have warfarin crosses the placenta. We do use it in pregnancy to treat difficult situations like mechanical heart valves. Direct oral anticoagulants cross the placenta as well. We don't have good data in how embryos and fetuses may respond, but warfarin does increase the risk of birth defects. Can't say what IV unfractionated heparin and enoxaparin at a higher dose might do here, but we chose enoxaparin at the same dose plus antithrombin concentrate. Next slide. And this is because she had recurrent thromboses despite anticoagulation. Next slide. He was maintained on maintenance doses of antithrombin concentrate on Monday, Wednesdays, and Fridays. She got home infusions to maintain her antithrombin levels in the 80 to 120% range. And then she threw a curveball at us. Next slide. She announced that she was moving out of state after we had carefully constructed this complex plan. She was moving to an area, though, that had a renowned hemophilia treatment center. We connected her with our hemostasis and thrombosis colleagues there. She continued to receive antithrombin concentrates during the pregnancy, and we learned at a national meeting that she had had a healthy infant at term and had done well. Next slide. So as Dr. Konkle mentioned from this study by Gerhard et al. That was published last year, risk estimates for antepartum and postpartum venous thromboembolism range from 3 to 47%, with the higher estimates derived from probably older retrospective family studies, possibly without objective confirmation of venous thromboembolism. Studies where the probands had already suffered venous thromboembolism, perhaps from families with more than one as yet undiscovered thrombophilia. And the lower range risks probably come because there is not usually a standard antithrombin level for the diagnosis of deficiency in these older studies. Next slide. So as Dr. Konkle mentioned, there was no significant increase in thrombosis in pregnancy in those with mild antithrombin deficiency, which was less than the 5th percentile in their study, which actually translated to antithrombin levels less than 90%. Well, that's pretty liberal inclusion criteria. But when they restricted the analysis to women with a level less than 60%, the odds ratio or risk was almost 50 times higher. And that was statistically significant. Next slide. So if the mother is at risk, what about the baby? This is the results of a systematic review published over 10 years ago. And you can see that the risk of venous thromboembolism is increased in women with antithrombin deficiency, but the risk of early loss, late loss, abruption, and preeclampsia did not appear to be increased, but this was also based on single studies with perhaps only 1 or 2 cases, so very underpowered to draw any conclusions. Next slide. So subsequent case series have suggested otherwise. Next slide. This is Folkeringa et al., published 10 years ago, and I'd like you to focus on the footnote. In women with antithrombin deficiency who received treatment during pregnancy with anticoagulation, none had fetal loss, but 63% of the women who were not treated who had antithrombin deficiency did have fetal loss. Well, there are a lot of confounders there because women who don't get treated may not have sought fetal or prenatal care for a variety of other reasons. They may have other risk factors, but it is suggestive. Next slide. These are data from Sabadell et al. In 2010, and I'd like you to look at the first 2 columns compared to the second 2 columns. In the first 2 columns are adverse, the number and the percent of adverse outcomes in women who received treatment with anticoagulation who had antithrombin deficiency. And in the second 2 columns are the numbers and the percent of adverse outcomes in women who didn't receive treatment with anticoagulation. Now, as you can see that although the numbers are small, there is a very high proportion of the women who didn't receive treatment who had adverse pregnancy outcome: thromboembolism, miscarriage, growth restriction, stillbirth, fetal distress, although based on very small numbers. Next slide. Now, we are limited in our inferences because there are few data in the literature specific to antithrombin deficiency, but there are studies of treatment in thrombophilia. And there are 4 very well done randomized controlled trials that showed no improvement in outcome in pregnancy in women who received anticoagulation. However, we don't know how many or if any of these women had antithrombin deficiency. Next slide. There are a couple other studies that showed improved pregnancy outcomes in women with thrombophilia who received anticoagulation. The FRUIT study showed decreased risk of severe preeclampsia in women who received dalteparin plus aspirin compared to aspirin alone. And then meta-analyses of randomized controlled trials of low molecular weight heparin in all women with a history of placental-mediated complications like preeclampsia, stillbirth, growth restriction showed a reduced risk in all women with low molecular weight heparin. However, a subsequent analysis of the individual data did not bear these findings out. Next slide. So what is the most recent evidence we have for treatment in antithrombin deficiency? I've just given you some conflicting information about anticoagulation and its power to reduce the risk of adverse pregnancy outcome. What about recent evidence for treatment in antithrombin deficiency, specifically, as opposed to thrombophilia in general? Next slide. This is a case series by Rogenhofer et al. They looked at 18 pregnancies in 7 women. They had 67 live births. Of the women who had losses, 2 out of 6 of the losses were late losses, which is unusual. In women in general, only 0.4% of pregnancies are lost late in gestation. All of these losses occurred in the group that were untreated, giving us additional evidence that anticoagulation improves fetal outcomes and reduces loss. 5 of these pregnancies were complicated by venous thromboembolism, 2 prior to thromboprophylaxis or anticoagulation being started, and 3 despite anticoagulation. In 5 pregnancies, patients were treated with antithrombin concentrate as well as low molecular weight heparin, 3 starting early and 2 starting at 34 weeks. Next slide. In another recent series from that same year, 2013, in another 18 pregnancies and 11 women, 94% had live births, but a third of them had small for gestational age infants. Their protocol was that if the patient had no history of venous thromboembolism, she received an intermediate dose of enoxaparin. If she had a history of venous thromboembolism, she received a full dose. Women stopped their anticoagulation at the initiation of labor and received antithrombin concentrate in the peripartum period. They started back on anticoagulation after delivery. And despite this very standardized, somewhat aggressive protocol, 4 of the pregnancies were complicated by venous thromboembolism, 1 newly presented, 2 due to noncompliance, and 1 despite enoxaparin. Next slide. So I should say that what the background risk of thromboembolism in pregnancy, although we who are in the field of hemostasis and thrombosis are very cognizant of it, the background rate among all women is only 1 to 2 per thousand. So you can see how extraordinarily high the risk is in women with antithrombin deficiency. We've talked about antithrombin concentrates now several times during the presentation, and their role is to normalize antithrombin levels in antithrombin deficient individuals, whether they have an acute venous thromboembolism, recurrent venous thromboembolism, etc. Next slide. So these are data that Dr. Konkle, Dr. Bauer, and myself published that were derived from the original study when plasma-derived antithrombin concentrate was introduced. And we just looked at the pregnant women. 6 women with venous thromboembolism during pregnancy were dosed according to the standard weight-based protocol and treated concomitantly with anticoagulation. The loading dose is described there. And then they got maintenance doses of 50 to 100% of the loading dose for 3 to 10 days at the time of the venous thromboembolic event. And then at the time of labor, they got a loading dose followed by a maintenance dose for 5 to 7 days. And those maintenance doses were 50 to 75% of the loading dose. None experienced recurrent thrombosis while receiving treatment with antithrombin concentrate. Next slide. These are data from the original study of recombinant antithrombin concentrate. This was published by Michael Paitis and several others of us. Among 21 pregnant patients who had hereditary antithrombin deficiency, a personal or family history of venous thromboembolism, and 2 documented antithrombin levels less than 60%, the following was done. There was an evaluation of the pharmacokinetic data from this study that revealed a higher clearance and volume of distribution for recombinant antithrombin in pregnant versus non-pregnant patients. There was a standard protocol for management of labor and delivery, which included initiation of treatment to the degree possible prior to delivery by about 24 hours and continuing for 3 to 14 days afterwards. The loading dose was per the package insert. And despite this close surveillance, 2 postpartum venous thromboembolism occurred among the women. Interestingly, they were both on prophylactic as opposed to therapeutic doses of anticoagulation, and in both cases, the antithrombin concentrate had already been, therapy had already been completed. They were not receiving antithrombin concentrate at the time of the events, and they were only on prophylactic anticoagulation. Next slide. So this high-risk situation compelled a group of us to gather to come to consensus on key questions. And our group was composed of maternal fetal medicine specialists, hematologists, and a basic scientist. And I will give you the summary of our consensus. I hope you can take it home with you. Slide number 1 of the consensus. Next slide. The first point that we came to consensus about was the need to establish a diagnosis. Given that antithrombin deficiency is uncommon and that laboratory tests may require expert interpretation, patients suspected of having antithrombin deficiency based either on family history or initial laboratory testing should be seen by a hemostasis thrombosis expert for confirmation of the diagnosis. I think that underscores what Dr. Konkle was saying. Next slide. This is antithrombin deficiency is a condition that really requires the input of multiple specialists, at least a hemostasis thrombosis expert, a maternal fetal medicine expert, the anesthesiologist, but also the laboratory team, the nursing staff, etc. Next slide. Our third point was that treatment needs to be stratified, and this was our consensus on treatment by stratum. For acute venous thromboembolism, we came to consensus that there should be full anticoagulation and antithrombin concentrates to normalize antithrombin. That's in the setting of acute venous thromboembolism in a patient who has antithrombin deficiency. For the patient who has a history of venous thromboembolism and is on long-term anticoagulation, and these are for all of these patients have antithrombin deficiency. Full anticoagulation and antithrombin concentrates when the anticoagulation is held. For the patient with a history of venous thromboembolism not on long-term anticoagulation, if the diagnosis is confirmed and antithrombin antithrombin level is less than 60%, treat as above. And if the antithrombin level is less than 60%, there's no personal history of venous thromboembolism, but there's a family history of venous thromboembolism. Our consensus was prophylactic or full anticoagulation plus or minus antithrombin concentrates when held. So some leeway in how that situation may be managed given patient preferences and other risk factors. Then we all agreed that anticoagulation should continue for 6 weeks postpartum in those patients. Now, what about the patient who has incidentally been found or somehow found to have an antithrombin level less than 60%, has no personal history of venous thromboembolism and no family history of venous thromboembolism? Well, it's not clear why they would have been tested in the first place, but one could consider a range of options, including antithrombin concentrates, particularly if the antithrombin levels are less than 40%, and at a minimum, anticoagulation for 6 weeks postpartum. So that's a lot of information, but our slide set will be available on the website afterwards. Plus, these recommendations have been summarized in an article I'll talk to you about momentarily. Next slide. So what if there are concerns about bleeding? First of all, we need to educate our anesthesiologists that antithrombin concentrates are not therapeutic anticoagulants. They restore antithrombin to normal levels, but they do not serve as an anticoagulant. They do not increase the risk of bleeding. A range of obstetric measures can be used to control bleeding in the patient at risk. What about the patient who is having excessive bleeding? The use of tranexamic acid may be considered. It has not been shown to increase the risk of thrombosis. And anticoagulants should be resumed as soon as bleeding has subsided and hemostasis is reassured. Number 5. Next slide. So because it seems like these patients may be at increased risk of adverse fetal events, some fetal surveillance should be implemented. And based on the patient's other obstetric risk factors and the fact that this is a high-risk thrombophilia, and the fact that there are some reports of an increased risk of fetal growth restriction, and I might add late fetal loss, including stillbirth. At a minimum, a plan should include serial ultrasounds for fetal growth. Number 6. Next slide. Oh, we're done. So this is the article I was talking about. We summarized, our expert panel summarized our consensus in this article that's available now online at Thrombosis Research. Next slide. May I turn it over to you, Evelyn?
Absolutely. Thank you very much, Dr. James and Dr. Konkle, and I'd like to thank you both for your excellent presentation. FWGBD is pleased to provide this webinar and continuing education credits free of charge. You can help support our educational work by answering the evaluation questions and the post-test questions so that we can demonstrate our educational impact to our funding partners. For participants of this webinar interested in receiving continuing education credits, instructions for applying for credit will be emailed to you shortly after this webinar has been completed. Next slide, please. At this time, we will proceed with the question and answer part of our program. As a reminder, participants can submit questions via the chat box in your GoToWebinar control panel. Questions will be answered in the order that they are received. And it looks like we already have one question from Dr. Roshni Kulkarni, who asked, do pregnant women with AT deficiency show placental infarcts that could account for the small for gestational age babies? And that's a really interesting anatomic and clinical pathologic correlation there. I'm curious about this myself.
So thank you for the question. 25% of term placentas show infarcts, but we don't have any data specific to the placentas of women with antithrombin deficiency so that we could say that the proportion of infarcts are higher. Can you hear me okay?
Yes.
Okay. So that is the postulated mechanism by which we believe adverse outcomes occur in high-risk thrombophilias, that there's impairment somewhere along the uteroplacental circulation, either at the maternal vascular level, in the intrauterine or the uteroplacental space, or within the placenta itself, either on the maternal side or potentially even on the fetal side.
Very interesting. I wanted to also take the opportunity to draw our participants' attention to the chat window. The link for the article that Dr. James was just describing, that you can find the link in the chat window so you can directly access that on your internet browser. I actually have a question for Dr. James and Dr. Konkle. as a not only a transfusion medicine physician, but also one who does apheresis, we are very aware that in doing frequent plasma exchange on patients who, for various reasons, they may be pregnant and receiving pheresis, or this can pertain to non-pregnant patients as well, that we can cause an acquired antithrombin deficiency. And for those patients who may already have thrombophilic risk factors, I'm just curious about your experience if you've ever worked with antithrombin concentrates in pheresis patients, if you have preference for either AT concentrates or plasma as a way of addressing acquired antithrombin deficiency.
This is, yeah, so that's an interesting question, and I would counter that in most circumstances, it would be very select circumstances that you would have to think of replacing antithrombin, and they might be most similar to patients with liver failure. Antithrombin's made in the liver. We know the values decrease, but you also have procoagulant values that decrease also. And so we have to be careful not to focus on one value without taking into consideration, because as I showed, there are lots of things that influence antithrombin level, and there's not a lot of evidence of that state being associated with an increased risk of thrombosis. There are questions of whether in nephrotic syndrome antithrombin gets low enough and is associated with the increased risk. Although a lot of people have nephrotic syndrome and low antithrombin levels, probably where replacement has been used most is with L-asparaginase therapy, which can really lower antithrombin levels. So I think if one was considering replacing, certainly it would be perhaps in someone who is on anticoagulation and at very high risk of thrombosis. So those are my thoughts in response to your question.
Great, very helpful. We've received another question from Leonardo Brandao. Do we know if there's any impact to the fetus with antithrombin replacement during pregnancy? For example, does it impact angiogenesis or other processes?
So I understood the question to be, do we know how antithrombin concentrate may affect fetal development or fetal outcomes? So we don't. We have very limited experience with antithrombin concentrate. There are several small case series. They're uncontrolled, so we don't have comparison. We might be able to make inferences that what we do know is that it appears that anticoagulation is necessary to reduce the risk of adverse outcome, or conversely, outcomes are improved with anticoagulation, and antithrombin concentration or concentrates may be necessary in order to achieve adequate anticoagulation when we're using a heparin, either low molecular weight heparin or intravenous heparin, because it is still what we consider the only safe anticoagulants in pregnancy. So if we need anticoagulation to improve pregnancy outcome, and then we may need antithrombin concentrates as an adjunct in high-risk situations around the time of venous thromboembolic events, or when anticoagulation is held for a procedure around the time of delivery to maintain circulation to the fetus. But in terms of, do we know at the time of implantation, at the time of embryogenesis, during trophoblastic invasion, how that may impact spiral artery dilation, for normal uteroplacental space. We don't have those. We don't have those data, but we also do know that whatever mechanism is involved, it's on the maternal side. However, it improves outcome, it's on the maternal side because it does not cross the placenta. All
right. Okay. And we thank you for that excellent answer. So I'll put out to the audience one more time. Any questions, any additional questions from the group? If not, this concludes our question and answer period. You will be able to review this webinar for your reference or share today's proceedings with your colleagues by visiting fwgbd.org and accessing this webinar under the Archived Webinars section. For those who may have questions on this material following the webinar, we encourage you to visit our Ask the Experts feature on our website and submit your question online. We thank you all for your attendance and participation today, and we look forward to your return for future Foundation webinars.